I'm Sarah Williams from ASH. I'm the Director of Policy here, and this morning we will be listening to a presentation from Allan Gregory, who is a member of the Tobacco Control Team at Public Health England. He will be speaking first on the work that Public Health England are doing to support this, and we will then hear a presentation from Louise Restrick, who is the respiratory physician in London, and she was previously a co-lead of the London Respiratory Network and a member of the London Senate Helping Smokers Quit team. We will then go to questions from the audience. Please feel free to ask questions as they come up during the presentation. We'll field these at the end. We'll have maybe about 15-20 minutes for questions, and if there are questions that we don't get to, then we'll write up a question and answer documents afterwards. So I will now hand over to Allan Gregory from Public Health England.
Thank you, Sarah. Hello, everybody. I hope you can all hear me now. I just want to reiterate my opening line was to say thank you to Sarah and colleagues at ASH for hosting the webinar and for giving us the opportunity to share some information with you all. I hope it's going to be very useful. We're going to rush through quite a lot of slides, I'm afraid, but hopefully I've edited them down accordingly, and there's a real opportunity at the end for you to ask questions as we go. So first of all, just like to start off with an opening statement or a premise that would underpin the rest of the presentation. And I'm sure it's a sentence here that you would totally all agree with. Smoking cessation support should be integral to secondary care. There are a number of reasons why it should be integral to secondary care. Firstly, stopping smoking at any time has considerable health benefits for people who smoke and those around them. And for people, especially using secondary care services, there are additional advantages, including shorter hospital stays, lower drug doses, fewer complications, higher survival rates, better wound healing, decreased infections, and fewer readmissions after surgery. The clinical benefits really sort of set out the case for smoking cessation in secondary care, and therefore I'd like to refer you to British Thoracic Society's work there, in particular for the case for change. The other key area to look at as well is something that is highlighted in the NICE PH48 guidance, and that is a duty of care. Secondary care providers have a duty of care to protect the health of people who use or work in their services and to promote healthy behaviour among them. This duty of care includes providing effective support to stop or abstain from smoking while using or working in secondary care services. So the case for smoking cessation in secondary care, it will not be the focus of this presentation. But we are going to actually just go along with the fact that is an integral premise for the presentation is that the value proposition for the NHS today is really smoking cessation in secondary care. I'm assuming no one would disagree with that. But so in that case, bearing in mind that that's the sort of underlying premise of the presentation, let's just move on to just give you a quick overview. There's a lot of attention and focus across the health system at the moment in regards to focusing on prevention. So I'd just like to sort of touch and go and see what the actual drivers are for that and what we mean by prevention, define those terms. And then we'll touch on sustainability and transformation plans, which is the big mode of delivery of NHS business for the coming 5 years. And we'll then look at how PHE have responded to that and to help support the preventative measures, which is an integral part of the STP plans, by looking at what's been termed a menu of preventative interventions, and look at some quick results that have come out recently, little successes we've had, which includes the national CQUIN for smoking cessation, which we'll touch on as well, and also highlight some of the tools and resources to help implementation. So first of all, prevention. Apologies for the busy slide, but I just want to give you the opportunity to sort of see where we're coming from here. We know that public health interventions, we always say that the more you can turn the taps off, the better. But in order to turn the greatest saving we're going to have in reducing smoking prevalence is to stop people starting in the first place. But we need to look at some of the short to medium time scale interventions that we can do as well in order to underpin the NHS sustainability agenda. So we need to look at individual behaviours, need to look at how services are provided in health and care settings so we can intervene earlier. And we also need to look at from a wider determinants of public health perspective as well, the environment we live and work in. And to that effect, NHS England have created a document they call the Prevention Aid Memoir. So this is looking at a number of different interventions across a suite of public health domains. And so there's a link there for you to have a look at, so you can see how NHS England are framing the prevention agenda for their local plans. And as we say, we use this term more often now, and this is all because of the austerity measures, NHS efficiencies, and even devolution as well, and the reductions to public health grants. So prevention is the good old age of prevention is better than cure. Is really the sort of dogma that we're managing ourselves in at the moment. So it's all very well saying, okay, we need to take more preventive actions, but we also need to look at how we're contributing towards the 5-year forward view and how we're going to look at implementing these. So just to reiterate, prevention key to sustainability. A big element of the 5-year forward view is how do we stop people getting ill in the first place, and also with that in mind, then prevention can save money and help support the ongoing sustainability agenda. Noting that obviously most of the costs we have with tobacco in particular is all preventable. So if we can stop people smoking or get them to change their behaviours sooner rather than later, we can reduce some of the burdens to the NHS down the line. And this is just something for you to reflect on, especially when talking to local NHS colleagues, especially local CCG commissioners and also clinicians as well. And prevention isn't new. So there's a long history around the quality, innovation, productivity and prevention program, or the QUIP programs in the NHS. So just bear in mind, quality prevention isn't new. This is just the next phase of its development and its plan, really. I just want to touch on sustainability and transformation plans. Sustainability and transformation plans is going to be a real focus for the next few years, and they come into play from April. And STPs are really acting as a vehicle for footprints to develop and implement joined up plans to close 3 gaps in the 5-year forward view. So this is the closing the health and wellbeing gaps, closing care and quality gaps, and the finance and efficiency gaps. And they build on existing plans, including health and wellbeing strategies and joint strategic needs assessments. The operational planning and contracting guidance that's been issued by the NHS asks that STPs are developed into 2-year operational plans. So the guidance has also announced that prevention is going to be one of the key areas of the and will be supported by a national transformation and efficiency program, end quote. So a key area of sustainability transformation plans will include actions around prevention. And looking at a lot of the STPs that have come in already, that have been published or we've got access to, if you look at your local STP, you'll find a section on prevention, and the vast majority of prevention plans and STPs up there in the country have targeted tobacco as one of their high priorities. Bearing in mind that the local government is an essential partner as well in developing STPs. They provide valuable public health advice to demonstrate how prevention can help to reduce demand for health and care services across the whole local system. But in particular, the key aspect about STPs is this actually should be a bottom-up approach, not a top-down approach. So we look at the STP footprints. It's about local areas working together to develop their plans. It's an opportunity for local organisations and local partners in the wider local health and wellbeing system to talk to each other, but also obviously to therefore improve the delivery of the health and care in their communities. It's also worth noting, and a lot of people have been asking me who leads these new organisations, and it's just to underpin the fact that they're not new organisations and they do not replace existing local bodies or change local accountability or legal responsibilities. This is about footprints, engaging with their communities to shape their plans, and even in some circumstances to carry out formal consultations if required. So there are 44 footprints up there in the country, and each of those footprints made up of clusters of CCGs, principally, have now now produced their plans for the next 5 years, and so within that is a suite of prevention actions. And to help support them on that way, PHE has produced a suite of a menu of preventative interventions, or the MOI, menu of interventions, as it's been shortened to. And this is building on the NHS England's prevention work so far, referring back to that NHS England Prevention Aid Memoir document that they produced. And it's a guide that's been developed to help local leaders work together across the STP footprints. Bear in mind that the menu of intervention is a work in progress, and PHE will welcome feedback from all system partners, and this will be continually updated as we go forward. So I'll just sort of give you a sort of an overview of the actual products within the menu of preventions. The resource aims sort of help local decision makers consider, which is the important element, the evidence-based public health and preventative interventions as they seek options to address their local challenges for the health and care planning process. The resources focus on obviously contributing towards the 5-year forward view, but it does not cover the full breadth of interventions that can help preventative ill health, particularly over longer time periods. So it's really focusing on the short to medium term time periods. It may be particularly useful when exploring the steps that health and care organisations need to take to deliver in the first 2 years of local STPs, because, as I say, we're looking for some quick wins in STPs over the first 2 years. So these menu of interventions are looking at those very short, medium-term gains. It's intended that local STP leaders and their teams, which will include local authority directors of public health and local providers of services, including those from primary care, acute and mental health trusts, and clinical commission groups, but also other partners as well. So again, it's not just aimed at the NHS or just aimed at local authorities, it's aimed at the wider system. For the menu of interventions to be useful in supporting local decisions, it needs to be complemented by local expertise. So as PHE being the sort of prime authors of this work, the local centre PHE staff and also staff from NICE as well can provide more targeted advice to support local teams in making decisions about addressing some of the proposals that have been put forward here. And also, there's an opportunity to link in right care delivery partners as well. They can be an assistance when considering these interventions in a local context. So I mentioned about the local context, but we're also looking at those interventions that we've sort of worked up and have been deemed to have the potential to deliver savings in the NHS in the first 5 years. There are at least 6 areas that have been identified. So they can improve health and well-being and save money for the health and or care system locally within a 5-year horizon. So as you can see there, we've got a couple around alcohol, one on hypertension, contraception and falls. But in particular, there are a number of interventions around tobacco, but one that we're highlighting in particular is around screening, advice and referral in secondary care. Now, all these interventions can be implemented in parts of the country, have been already implemented in parts of the country, and they've proven to be effective, and they've also generally based on NICE guidance or recommendations, so they shouldn't be a real surprise to anybody really. But details of the potential savings and benefits from these interventions can also be found in the menu of interventions document that's published online, and the links are in this presentation. So you can look at some of the potential savings and benefits from introducing some of these. Okay, before we go into more detail around some of these, we need to give you that sort of caveat, really. PHE has sort of produced earlier versions of the MOI, and as I say, they've been disseminated with lots of feedback, and we continue to have that sort of feedback mechanism going back and forth. So any opportunities, anything you see in here is an opportunity for you to feedback if you want to raise more opportunities for us to focus on particular areas. We've included interventions in the MOI where there's potential to address key aspects of preventable ill health. They've not been selected as part of a systematic review of the evidence, nor in order in which they are presented as a ranking of the interventions at all. and the list is not exhaustive. PHE has quality assured the evidence in the analysis, and figures are likely to be subject to change as a result of new evidence becoming available. So caution should be taken when interpreting and using the information provided. But PHE recommends that any advice from this document is triangulated and published with peer-reviewed evidence, and you may be aware of, or adapted to reflect local circumstances. So it's just to say this should be seen as inspiration and evidence-based interventions, and as an opportunity locally for you to develop them further. So with regards to tobacco, as you can see there, this is sort of just an overview of the case really. We know smoking is the single largest cause of health inequalities and premature death. We know around the annual cost of smoking to the public is high, and estimates of the cost of the NHS circa 2 billion plus. There's also a cost of social care as well. But we also know, as I reiterated earlier, that the biggest short-term saving opportunities lies in helping smokers are in contact with the NHS. The longest-term savings would obviously come from preventing people from ever smoking altogether, but the biggest short-term savings is helping those who are already in contact with the NHS. And so we have 4 interventions that have been proposed under tobacco. The first is providing screening, advice and referral in secondary care settings. This in essence is the implementation of PH48, NICE guidance PH48. But in particular, the key element there is we should be ensuring that the care plan of patients at discharge, if a patient smokes, their care plan should address their tobacco dependence. We've also got some interventions worked up around looking at smoking harm reduction, and this is particularly around when patients are admitted. We may want to help them cut down to quit, and also in the long term give them some other alternative nicotine use to prevent relapse of smoking. So it's not just about abstinence while they're in hospital, but it's about those who are unwilling to quit, what other support we can do from them. We've also got a focus on smoking and pregnancy, and we've also got some focus here on mental health, particularly around mental health trusts as well. All of these are in the menu online and online on the menu interventions webpage, but which is also a document you can download, and they also give a sort of state the case why we should be focused on the areas, but also give some evidence and also give some cost effectiveness details as well. And there's some links there to support you on how you can use other tools to help localize the interventions. I'm just going to focus on that very first one as an example here to give you some more detail of what's in them. So the first one around assessment, very brief advice and referral in hospitals. We'll seek to achieve this through a comprehensive approach as per NICE PH48. And as you can see there, this is about assessing and recording smoking status, about providing very brief advice, offering smokers access to specialists in situ quitting support, automatic referral for intensive behavioural support and other specialist treatment, and naturally making secondary care settings smoke-free, and also looking at, where relevant, the training of healthcare staff to deliver the interventions as well. So success will also require continuing care after discharge from hospital. That's the most important element here. So patients who smoke should leave hospital with a clear treatment plan to address their tobacco dependence. And there's obviously examples that were given, include the CQUIN that's been introduced at the Whittington Health Hospital, and you'll be hear a little bit more about that and other interventions that will be led at Whittington later in this presentation. As well as saying what the aim is and what we're trying to do, we also put forward some measures around the effectiveness. So we know that quit rates among patients who want to quit and take up a referral are higher than those who don't get a referral. So it's not about just, we record smoking status very well in hospitals, but we don't necessarily offer, or at least record the offer of an intervention and an onward referral. We've also got some examples of cost and net savings that are modelled in the menu of interventions, and there's opportunities again for you to sort of apply your local figures and an opportunity to actually try and replicate those those costs and net savings into your local area. And there's a number of progress indicators which aren't just looking at those ones there, but there's an opportunity, there's lots of other progress areas that are highlighted throughout the document. I'm going to quickly go through to the next section now to say one of the big things that's happened as a result of the STP sort of debates that have been going on in the planning process is the agreement for a national CQUIN. So we're going to have a national CQUIN in secondary care now. There's a number of CQUINs been agreed, but the one we want to look at, in particular at the bottom here, is preventing ill health by risky behaviours. And this is a CQUIN which looks at tobacco and alcohol. It's entitled Preventing Ill Health by Risky Behaviours, and it focuses on the screening of smoking status. If I just focus on the tobacco element, focus on smoking status being recorded, delivery of brief advice, and onward referral to cessation support. So in year 1, the delivery will be in community and mental health settings, and in year 2, and it'll be delivery in acute settings. So community mental health settings starts from April this year, and our acute providers have another year's run-in in order to hit the ground running for April 2018. Now, National CQUIN underpins the STP process and sort of prioritises local action with smokers in hospitals. There's some details there around partial payments, but I won't go into too much detail on that at the moment. Basically, we've had a lot of feedback from CCG commissioners in particular, who seem to be universally applying the CQUIN to their local contracts. I just want to sort of signpost a few tools. So if you're looking to help services locally or your local communities look at these menu of interventions, there's some tools to help this. So the case has been made around PH48, and all these tools really say implement PH48. That's the bottom line. But very quickly, my last slide. So the implementation of NICE guidance, therefore, is around the PHE has sort of developed a suite of tools around implementing PH48 in mental health settings. And watch this space, we should have an acute secondary care version of those tools, or at least the documentation tools to help you do a little assessment, coming up very, very soon. We already referenced the British Thoracic Society's Case for Change. A really good, excellent read. Please read it, and it'll fit in lots of the gaps in the background to this presentation in particular. And the NCSCT has a lot of information about supporting the clinical case for providing stop smoking support to hospitalised patients, and that includes a suite of documents for individual specialties. So if you need to make representation at particular clinical networks locally, that's a way in. And obviously, in terms of this being a system approach rather than just down to organisations to do, there's an opportunity for people to look at the clear local tobacco control assessment process again, so you can actually look at the support you get from engaging NHS bodies and NHS commissioners and how they can do some joined up working there. And there's lots of good commissioning prompts in the JSNA resources. But one of the heaviest set of resources that we've lent on over the last year to 18 months has come from some practical feedback for on the ground of how a network has actually run with not only CQUINs but also getting the agenda of helping smokers quit embedded across the local partners, and that's from the London Clinical Senate programme. So there's a suite of resources there which I urge you to review. But in the meantime, I think that's the end for my presentation, and it's an opportunity for me to pass you on to Sarah, who to introduce Louise from London. Take care now.
That's great. Thank you very much, Alan. And just before I do hand over to Louise, it's just a reminder that if you do have questions, then feel free to ask them, and you should be able to see a chat box. And if you type your questions into there, we'll be fielding them at the end. Thanks. And I'll hand over to Louise. Thank you very much, and as Alan said, thank you very much to Sarah and the ASH team for setting up this webinar, which it's a pleasure to be a part of. I want to talk for the next 20 minutes before we both take questions with a slight change in emphasis, and I want to talk about the diagnosis and treatment of tobacco dependence. And I'm really going to talk about 3 themes. And we think the language that's used is really important in terms of engaging clinicians.
So the first thing is that over the last few years, we're now talking about smoking being an addiction, and it's a relapsing and remitting long-term condition that usually starts in childhood. This is we found really important because it's a way of engaging clinicians. I'm going to talk a bit more about that. So I also want to talk about, as a clinician, what our roles and responsibilities are and should be wherever we see patients where smoking is impacting on their health. And then in order to do that, we need to think slightly differently about making sure our clinicians have the right training, the right equipment, and the right medication. And actually, quite a lot of what I'm going to talk about, we talk about patients' motivation to quit smoking, but we probably also need to talk a bit about clinicians' motivations to get involved in treating tobacco dependence, people's beliefs which guide their behaviours and therefore motivate clinicians to be involved in this kind of work. So before I go into the detail, as Sarah said, I work as an integrated respiratory physician in London, and I think because I'm going to talk about medication and equipment, it's very important to state clearly that I have no financial declarations of interest. Because I work as a respiratory physician, that means I'm a long-term condition clinician. It means I lead and work in a team, I care about value, and I know, I hope, at least a little bit, how to do and lead quality improvement. While I don't have any financial declarations, I have been very influenced and lucky to work in a number of fantastic teams where there's been significant collective clinical leadership, both the respiratory team at Whittington Health, my colleagues in the London Respiratory Network, and the work that I want to share from the London Senate Helping Smokers Quit team. And you will see on this slide a picture of my colleague Myra Stern, who I think it is really important to acknowledge because she's been very influential in this change, both in terms of leading the work we've done as a culture change at the Whittington, but also as one of the key authors of the BTS report that Alan referred to in his talk. So to engage clinicians, we really need to understand what makes us tick, and that we are largely driven by an evidence base, wanting to make a difference in terms of patient outcomes. So I want to talk a little bit about the journey that shaped our cultural change, and then a little bit about the how-to. How do we believe this is important? How do we get confident at doing it? And therefore, how does it become part of what we do? So that's really about culture. So I'm just going to use London as an example. This is a map of London that we've been using for the last 6 years or so. And the areas in purple, and you can see where I work, are where 1 in 5 people walking the streets or in their homes die from smoking. And this is the kind of information that's really started to shape changing how we think about the people we see in front of us. So overall, there are more than 1 million smokers in London, causes more than 8,000 deaths, and it costs the NHS in London alone £250 million. That aligns with the data Alan's given you. However, if you talk about it as population data and lifestyle choice, clinicians will not get involved because historically that's been seen as public health responsibility. And I think that's one of the things that may come up in the discussion, that we really need to talk about when is it right to use the language of prevention and when is it right to use the language of treatment. So although I'm a respiratory physician, I look after many people with serious mental illness, and there are a couple of areas that I just want to put one slide up to show that this is really a system-wide approach that's needed. So if we want to reduce mortality, actually we also want to look at the age of death. And many of you will have read the No Health Without Mental Health fantastic white paper that was published actually nearly 6 years ago now, which confirmed what we knew in practice, that nearly half of all tobacco is smoked by adults with mental health problems, and the impact of tobacco dependence is massive. Not only do people die with a much greater prevalence of deaths that are smoking related, but they also die on average 16 to 25 years sooner, which is a massive inequality gap. One of the reasons this is interesting for us as respiratory physicians is this population has a very high prevalence of high tobacco dependence, which is exactly the same as many of the people I look after with COPD. There isn't a single patient with COPD who still smokes who doesn't know they shouldn't. It's just if you're highly dependent, it's very difficult to stop. Really important to go back even younger and just flag an issue in a disease that perhaps isn't always associated as being related to smoking, which is asthma. Again, many of you will have seen the National Review of Asthma Deaths report, and perhaps will have picked up that 1 in 3 of the deaths in children were in smoking families, but in 1 of the 10 deaths in under 10-year-olds was a child who was a smoker. And as I've said, we find it really helpful to talk about smoking as being a relapsing, remitting, long-term condition that starts in childhood. The Surgeon General in the States recognized back in 2014 that there is evidence that smoking is causative of asthma exacerbation, so this is really important for hospital admissions. There's the Sarah Purdy population data, which shows that the situation is exactly the same in asthma as it is in COPD. For every 1% increase in prevalence of smoking rates in your asthma population, you will have a 1% increase in admission rates. And the BTS, which runs an excellent asthma audit, now includes data on smoking prevalence in adults admitted to hospital. We've been looking at this for even longer than that audit, and for us as an inner city hospital in London, it varies from year to year, but is systematically more than 40% of people admitted with asthma are tobacco dependent. I think there is rightly a really strong evidence in what happens in pregnancy, and although this isn't directly my area, as you can see from this slide, the evidence for the involvement of midwives and obstetricians in commissioning and delivering maternity pathways that have a really strong focus on identifying and treating tobacco dependence with formal measures using cotinine or carbon monoxide measurements is clearly a really important area. So just coming back to that map that has driven what we've been thinking about doing in respiratory, you can see the range of conditions that this impacts on. So the next step is, what's this got to do with me as a clinician? And by thinking about this in a slightly different way, what we know and what I know is that 1 in 3 of the people I and the team I work with look after as a respiratory physician will die as a result of smoking. And we have lots of opportunities to intervene and work with these patients wherever we see them. The other thing that has made a really big difference is using the value framework that Michael Porter has introduced. This works for clinicians because we care about health outcomes. It enables us to have really effective conversations with our commissioners because value is delivering the best possible outcome for the cheapest possible cost. And when we took this into our London respiratory thinking over the last 5 years, it made us want to look at COPD and value and see what the value-based interventions were. And there's been a lot of emphasis on inhaled therapy and triple therapy in COPD, but if you actually look at the value-based interventions, and this pyramid I think is now quite widely used as a really useful visual for thinking about where we want to prioritize our interventions, you can see how cost-effective treating tobacco dependence is in people with COPD. It comes in at £2,000 per QALY, which is way, way below the NICE cutoff. So as a result of all of this, and because we had Myra's leadership at the Whittington, we started to think, okay, tobacco dependence, long-term condition, that's something we need to treat. We look after many people in hospital whose admission is partly driven by tobacco dependence. So we need a team who know how to deliver behaviour change interventions, prescribe smoking cessation medication, and we need to be doing this with our smoking cessation specialists. And the most effective medication for people who are highly tobacco dependent and sick and who have tried lots of other smoking medications is varenicline. And so this is what we do at the Whittington now. It's become part of how we work. Treating tobacco dependence is part of all the team's responsibility. I think one of the things that has been important is that we, as a group of consultants, do it, talk about it, lead on it. We have an ethos where all of the team have had some motivational interview training, that we have a smoking cessation specialist who comes on the board round with us, and that this is incremental work. You don't do it in one go. And as Allan said, and I was delighted to hear, the follow-up is absolutely important, is key. There's no point putting lots of work in place in hospital when actually there's an environment where it's really hard to smoke, if when someone goes home they're left on their own and just find it too difficult. The other thing is, as a really nice, easy bit of kit, we now have a carbon monoxide monitor that we use as clinicians in clinic, on home visits, and on the ward. And of course, we work closely with our pharmacists so that we have the full range of nicotine replacement and varenicline. So that we're one relatively small integrated care organisation in London. I was really lucky to be part of a 2-year programme that the London Clinical Senate set up, which was a Helping Smokers Quit programme. And you've already heard what the aim of that programme is. And I really wanted to share some of the hope and how-to that has come from being involved in that programme. And we developed a tag to try and make it easy for people to remember the interventions, which is called CO4. So I just want to touch on some of the 4 components of CO4. First of all, enabling staff to have the right conversation that is going to effectively support smoking cessation. Making carbon monoxide monitoring by clinicians part of what we do. Coding the status of patients who smoke and commissioning the system to do the right thing, which fits very much with the STP discussion we were talking about. So there are so many resources out there for enabling conversations, and one of our recommendations in the Helping Smokers Quit report is that it should be made mandatory for all health professionals do very brief advice training, which takes 20 minutes. We have lots of other mandatory training that we have to do, and in terms of priorities, my personal view would be that this would be right up there. The reality of enabling conversations is, again, it's about what happens on the day-to-day, and I can't recommend strongly enough the power of having a smoking cessation specialist, and I use the term specialist rather than advisor deliberately, working in clinical teams, because you get so much skill and knowledge transfer both ways. And you can see on this slide the Quit at the Wit box, which is a box that Myra developed that we all use routinely now, which allows clinicians to put their hands on quit smoking medication. And you can see the various settings where we've been putting carbon monoxide monitors into the design of new services. This is the arrival of our new CO machine. This is the London Respiratory Network having training in smoking cessation. This is smoking cessation being delivered within the COPD discharge bundle and using the CO monitor in clinic. I just put this in to say, if we are going to do behaviour change and motivational interviewing, we've been really lucky at the Whittington because we've been able to show that this is a cost-effective thing to do. The people who can really train us to do this are psychologists. The reason I use a CO machine, and I have one in my bag because I'm on my way to the Whittington after this webinar, is that it's cheap. It only costs £150. It's very easy to use. It's a fantastic diagnostic tool, but most importantly, patients like to use it because it's a motivational tool. And one of the products that the Helping Smokers Quit team has produced is a guide to health professionals of how to use a CO machine with a RAG chart, which works really well with patients. And on the back of this is the guidance from the psychologist of the language you might use with each level that you get. This is varenicline prescribing across London. and we talk a lot about variation. And without going into detail, I think you can probably see there's quite a lot of unwarranted variation here in how much varenicline is prescribed in a CCG and how much varenicline is prescribed in an acute trust. And here we are as a tiny acute trust as the Whittington, and yet we're one of the biggest prescribers because we believe that's what we should be doing. So why aren't clinicians prescribing varenicline? And you heard about the importance of pH 48, which I think was published in 2013. So that's 3 years ago, but still isn't happening. That's because clinicians perhaps aren't confident to prescribe it because it's always belonged to smoking cessation specialists. So these are tools that we think might enable clinicians to use the medication. The next thing is coding. And I won't talk about this in detail, but happy to take questions. We don't really understand why tobacco smoking history isn't on death certificates in people where the diseases have been caused by smoking, particularly thinking about lung cancer, but it isn't. And again, as the London Senate team, we have a resource to help do this. And in Southampton, where they've been piloting an internal medical examiner scheme, they have introduced this within their system. So if you want to learn more about it, I would speak to the Southampton team. So I just want to end with perhaps the most important data that's out there. So this is what we do, this is what I do, this is what we do. And the reason we do it is it's obvious to us for the immediate patients in front of us that it works. I've been a consultant for 20 years this year, and actually I still like learning new skills. But we also need to, we believe it's high value, we need to know about its value. And I don't know if any of you have seen this study, but if you haven't, I strongly recommend having a look at it. So this is a study that was published last year from Ontario, where they used exactly the same model that I've been describing to you today, which is in the PHE guidance, in the BTS guidance. And they did a two-group effectiveness study. So they compared before and after in hospitals where they introduced this approach to treating tobacco dependence. This first graph is the impact of doing this on mortality. And this is over 2 years. And the first thing to say, and Myra and I couldn't believe this when we saw it, that it could happen so quickly, and we would like to look again at the English data, is that mortality is halved with this intervention by a year. You don't have to wait 5 years. Reduction in mortality was from 11% to 5%. The next thing, when we think about STPs, is readmissions. And look what happened at readmissions, and look what happened by 30 days. By 30 days, readmissions were reduced in half. And that risk reduction was maintained and widened all the way through to 2 years. So my final slide, before we're happy to take questions, would be to say, why isn't this firmly embedded in all STPs? I think our messages from the London Senate are very similar to the messages that Allan gave you. We know where the people who are sick from smoking are, and we need to get on with systematically identifying and treating tobacco dependence in an evidence-based way as clinicians. Thank you.
That's great. Thank you very much, both Louise and Allan, for their presentation. We have a few minutes for questions, and we've had some great questions. So anyone who don't get a chance to answer this today, we will be able to put in a question and answer document and send that round afterwards. So first of all, we have a question, I think, for Allan, which is, will PHE be gathering and publishing other examples of good practice for implementation, for example, CQUIN?
Short answer, yes. So yes, short answer, yes. We're looking to manage a program of events and support over the coming year in particular. So we're always on the lookout for good local examples of not only implementation of CQUINs, but also examples that of activity that Louise has mentioned as well, in terms of trying to overcome some of the barriers and trying to look at some of the people who have overcome the sort of cultural issues and the sort of good examples of good local leadership in particular.
Thanks, Alan. We've had a question for Louise as well, which is, at the Whittington, who does and funds the follow-up at home? Is it your trust, the local authority, or the Stop Smoking Service?
Thank you. That's a really good question. In the talk, I was telling a story of hope, and for us, like for everyone else, this is very challenging. So historically, the smoking cessation specialist who worked with the respiratory team was funded by Islington CCG, which has been absolutely excellent for us and was part of the delivered smoking cessation service. As is the case in many places, there is currently recommissioning of the smoking cessation service by our two local authorities, and the post we have currently continues to be funded till the middle of this year, and I think we need to see how that pans out within the new service, and that may be more of a challenge. I'm not quite sure yet.
Okay. A question for Alan, which is, will smoke-free NHS sites be part of the CQUIN? Because there's some resistance to this locally.
Okay, well, first of all, the CQUIN is aimed at inpatients, and what we would say there is the CQUIN is obviously to incentivise at local action. So it's primarily aimed at inpatients, but we've known from feedback and experience from other people who've rolled out CQUINs as well, is that in order to get the best compliance of that CQUIN is to do a comprehensive set of measures. So if we're looking at pH48, you wouldn't just necessarily just focus your efforts on inpatient pathways. You would include your outpatient pathways as well, your day case pathways, and also you'll be trying to do as much around pH48 as possible, rather than just the intervention, the face-to-face intervention with a patient. So you would probably support want to go for a complete adherence to pH48, which will include smoke-free grounds. So it's not explicit to the CQUIN, but the CQUIN is to incentivise some action, but to do comprehensive action, you look wider than just what the CQUIN is asking. So the CQUIN doesn't ask for smoke-free sites, but the rest of the but in order to actually get good compliance with the CQUIN and get clinicians and managers embedding it into all their work, you want to go, I would recommend you go for the whole of pH48 as much as possible.
Thanks, Alan. And another question on the CQUIN, which is the CQUIN mandatory or optional for trusts? Okay,
it's mandatory. But having said that, it's a national CQUIN. It's mandatory for trusts where it applies to those particular trusts, whether they're mental health trusts or secondary care acute trust. But bear in mind, what CQUIN means is that you have to adhere to the quality indicator, and then you then given over a percentage of the money that was withheld. Obviously, some trusts may want to decide that they're not going to do this, and therefore they won't. They actually sort of write off that percentage of money that's been held back. But the question would be, why would they do that? Especially as we mentioned before, that treating smokers, or supporting patients who smoke to quit is the right thing to do. So it is a mandatory CQUIN, but it's for CCGs to embed that into their contract with the local trusts.
Thanks, Alan. And we've just got time for one last question. And just to remind people that we will be able to sort of send these around in a document afterwards, which is, will e-referrals be nationally launched?
As far as I'm aware, and this is where I probably need to get some more counsel as well on this one. There was a launch of a national referral system, but it's down to local areas to buy into that system to make sure that their information systems can support it, for example. So there won't be any, as far as I'm aware, large-scale rollout of a new mandatory e-referral system, but facilities currently exist, and it's down to local decision makers to decide whether they buy into that.
Thank you very much. So this brings us to the end of the webinar. I'd just like to thank Alan and Louise for their time and for their excellent presentations, and to the audience for their questions as well. In terms of following this up, we will be putting the webinar online, and we can also circulate, hopefully next week, a link to some of the tools and information that have been mentioned in today's webinar as well, because I know we've covered a lot of really useful information, and we will also be writing the audience questions up with written answers and circulating that in a document. So thank you very much.